This lecture will cover neurodegenerative disorders of the cortex, focusing on Alzheimer's disease and amyotrophic lateral sclerosis, or ALS, or Lou Gehrig's disease. It's got a few names. In both of these cases, we're going to see degeneration of neurons in the cortex. That's why they're grouped together. Also, in both of these conditions, we see a lot of protein aggregates. Now, in Alzheimer's disease, what we'll see is a collection of both extracellular amyloid plaques, as well as intracellular neurofibrillary tangles. This is also showing us tangles and plaques just with fluorescence. In ALS, we see protein aggregates, but it's different proteins, and it's in different neurons. Now, ALS is going to step outside of the cortex and affect lower motor neurons in the brainstem and spinal cord as well. So these two disorders have something in common. That is, we're going to see protein aggregation and degeneration in the cortex. They'll focus on different parts of the cortex. Alzheimer's disease won't really have a whole lot of motor symptoms until very late in the disorder, whereas ALS is primarily degeneration of motor neurons without affecting cognitive function. So to some degree, the two disorders are similar, but in other respects, they're completely different. We'll start off with Alzheimer's disease here. This is a dementia, so by definition, this affects cognitive function. And Alzheimer's disease primarily affects memory. This will go on to affect other aspects of cognition, such as judgment and calculation, but memory is one of the primary deficits in Alzheimer's disease, and this has to do with the brain regions affected. The characteristic features, aside from the dementia and the degeneration, are the plaques and tangles. If you have dementia without plaques and tangles, you don't have Alzheimer's disease. Alzheimer's disease is unfortunately quite common in old age. Here we can see the risk across age groups. We're not finding a whole lot of 5-year-olds with dementia, but once we get into about our 5th decade of life, here the number becomes not 0. I believe the earliest recorded case is about 17 years old, but don't quote me on that. That's incredibly rare. Familial cases, which are only about 1% of all cases of Alzheimer's disease, those come on earlier. So here we'll start to see them in the 40s, 50s. It's not until we get beyond 65 years of age that we start to see the sporadic or non-familial cases. So here's where that line really takes off once we get into our 7th decade of life or so. And what you'll notice is that females have a slightly higher risk than males. This is the case. It may be a 20% increase. It might be a doubling. It totally depends on the study. But across many studies, females have a higher risk of Alzheimer's disease. Don't worry, ladies, this is going to flip when we get into the second part of this talk. The other risk is having mild cognitive impairment. So if we already have cognitive deficits, you're quite likely to develop Alzheimer's disease. There we see about 1/3 of folks with mild cognitive impairment progress to Alzheimer's disease, and it's about a 10% annual rate. So every year, about 10% of the folks with MCI develop Alzheimer's disease. Another big risk factor is diabetes. So age, obviously a huge risk factor. Female sex, we just went through that one. Stroke can increase the risk because it just damages the brain and decreases cognitive function, making it more likely for any dementia to develop. In fact, if you have a whole lot of strokes, this creates what we call vascular dementia. Men have a much higher risk of vascular dementia than women, whereas women have a higher risk of Alzheimer's dementia. But you'll notice right up top here, diabetes. Alzheimer's disease is called by some folks type 3 diabetes, meaning just insulin resistance in the central nervous system. Now, in fact, the use of insulin therapy further heightens the risk of developing Alzheimer's disease in folks with diabetes. I guess the idea there is that high doses of insulin exacerbate insulin insensitivity in the central nervous system. There might be some other links, coronary artery disease. These are reported in some studies. You can see that's certainly not the case here, right? So there are some cardiovascular risks that might be there. Some folks are really big on the Mediterranean diet or eating blueberries or drinking coconut oil. And sure, you can find studies that say they're helpful, but, they're not really replicated. So we're not going to think of diet as a huge risk factor here. Obviously, eat your fruits and veggies. But we are going to think of diabetes as a huge risk factor because it is. You can see it about doubles your risk of developing Alzheimer's disease. Now, there is something related to fats and how we handle them that is a major risk factor, but it's not fatty diets or anything like that. It's which apolipoprotein allele you have. So apolipoprotein, or ApoE, comes in a few variants. So there's ApoE4, right? We can get 3 and 2 as well. So we've got 3 alleles here for the ApoE4 gene. Now, depending on which of these alleles you have, epsilon 2, 3, or 4, that determines your risk of Alzheimer's disease. So here we can see the dose dependence here. So if you don't have a single epsilon 4 allele, your risk of dementia we're going to call 1. You can see about 4% of the folks had dementia in this group. If you were a carrier of a single allele, that's right here, so a hemizygote, or a heterozygote, I suppose, your risk of dementia doubles. So a little over 8% of them had dementia. And if you have 2 copies, sure, it's a much smaller group, but across numerous studies, this dramatically increases your risk of dementia. So non-carriers, if we have a look at this little human plot I made for you, so each person's about 10%. Red means you're guaranteed to get it. Purple is the maybe, because there's a range, right? Somewhere between 9 to 20% of people we think are going to develop Alzheimer's dementia if they don't have the epsilon 4 allele. So we'll say, 10 to 20% here. And the rest of the 80 to 90, this one's a who knows. Notice it's not red or blue, it's kind of purple. The rest of the folks will be fine. Now, if you have ApoE4, right, if you have the epsilon 4 allele and 2 copies of it, half of the people will get it, and another 40% on top of that might get it. So we see a range of 50 to 90% developing dementia, with only 10% of folks guaranteed safe. This has to do with the age of onset. In folks who don't have that epsilon 4 allele, the typical age of onset is 84. So this is quite old. This is, I'm pretty sure, still beyond our average life expectancy. Folks who have 2 copies of the epsilon 4 allele are going to develop it much earlier. So we see dementia coming on around the age of 68. So we'll see if we can link this ApoE4 allele to Alzheimer's risk later on. When we look at the cytological hallmarks of Alzheimer's disease, we see plaques, tangles, and a whole bunch of atrophy. So there's severe atrophy of the cortex. Here's a slice of the cortex from someone with Alzheimer's disease, and here's a healthy age-matched control. Notice the dramatic decrease in brain size. Now, everyone's cortex atrophies, but we see about a doubling of that rate in people with Alzheimer's disease. So whereas everyone is going to lose about 0.4% of their cortex every year, folks with Alzheimer's disease are losing about 0.7%. So about twice the rate of degeneration. Most noticeably, we see this in the hippocampus. So right here in the medial temporal lobes, there's the hippocampus, there's the hippocampus. In Alzheimer's disease, it degenerates at about a 7-fold higher rate than in the rest of us. In addition to severe atrophy, we see these extracellular amyloid plaques. Here they are again. And these intracellular neurofibrillary tangles. Here they are again. So we got some protein aggregates. Plaques are made of A beta, and those are extracellular. tangles are made of tau, and those are intracellular. Now, the familial Alzheimer's cases, although they're rare, are quite informative about how the disease progresses. Familial cases of Alzheimer's disease all involve some increase in the production of A beta, and in particular, A beta 42. All right, so A beta is made from this protein called the amyloid precursor protein. So here's a cell membrane, and here's a protein sticking through it. That's the amyloid precursor protein. Only a small portion of this, if we follow the blow up here, is going to become A beta. That's the red part. So there's a couple of enzymes called the beta secretase, or base 1, and gamma secretase, which is made of the presenilin proteins. When these cut APP in these two sites, it liberates this red, nasty A beta. And this happens anytime a neuron's active. So you're making A beta right now, so am I. So any of us could potentially develop Alzheimer's disease. That's why it's such a common disorder. Anywho, let's take a look at the sequence of A beta here. And what you'll notice, here's the beta secretase cut site over here. And here's the gamma secretase cut site. Here's where we have a couple of options. Beta secretase always cuts here. Gamma secretase can cut either here or here, and actually there's even more variability than that. But most commonly we see an A beta that's 40 amino acids long, or that's 42 amino acids long. And those two extra amino acids, if you'll notice my color coding, are non-polar. So all the blue amino acids are polar or charged, and the red ones are non-polar. Now, if it's non-polar, that means it tends not to be soluble in water, so it's a little more aggregation prone. So A beta 42 is going to tend to stick to itself. It'll form those plaques that we just saw, and it'll also form an intermediate structure called an A beta oligomer. Okay, so we've got some variability in what kind of A beta we make. All of us make A beta 40 and A beta 42. And what we find in those familial Alzheimer's disease mutations is that they increase the amount of A beta, and in particular, the amount of A beta 42. So here we've got several mutations. I color-coded the red ones to be increasing the risk. There's one green one here that actually decreases the risk of Alzheimer's disease, and what it does is mutate that beta secretase cut site so that beta secretase doesn't cut as often. So this Icelandic mutation here actually decreases the risk of Alzheimer's disease by decreasing A beta production. The rest of them increase A beta production, either the overall amount, so there's the Swedish mutation that also affects the beta secretase cut site, but it actually increases beta secretase activity. So more A beta. We can also prevent another secretase from cutting, again, more A beta. These bottom two, the Florida and London mutations, increase the amount of A beta 42 that is made. So they alter the cut site of gamma secretase. And then there's, over 100 mutations in gamma secretase, either presenilin 1 or 2. But gamma secretase mutations also increase A beta 42 production. And then there's a couple of nifty mutations that cause A beta to stick to itself better without necessarily changing the ratio or anything like that. Either way, if you have more A beta, and in particular A beta 42, you have a much greater risk of Alzheimer's disease. Now, those sporadic Alzheimer's disease mutations would be in the ApoE4 allele. They're not really mutations, it's just which allele do you have. So there's ApoE3, 2, and 4. 2 and 3 we're going to call okay. ApoE4, not so much. So ApoE4 is a problem because it doesn't stick to A beta as well. What we're doing here is looking at binding of A beta 42 to ApoE, right? So these lines, as they're going up, that means we're binding more A beta. And so you can bind up all the A beta with relatively low concentrations of ApoE2 or 3. And that's the two that are shown here. I only labeled one. Okay, so really low concentrations of ApoE are needed to bind up all the A beta. On the other hand, you add like 100 times that amount of ApoE4, and only then are we just barely starting to bind up all the A beta. So the fact that this ApoE4 curve doesn't rise up as quickly, that means that ApoE4 doesn't bind A beta as well. Now we want ApoE4 to bind to A beta because this is the protein that escorts A beta out of the central nervous system. This might be easier to see in a figure here. So we've got our A beta floating around. Now, what are its fates? Well, it could be taken up by a glial cell, maybe. It might be degraded enzymatically, but more commonly what we're doing is clearing it out to the blood. And that requires ApoE to bind to it. ApoE3 or 2 is going to do a much better job than 4. So if you have that ApoE4 allele, we're not really removing you. And we're not going to break you down or pick you up into a glial cell. What does that leave us with? This one option right here. Stick to yourself and aggregate. This is why ApoE4 is going to be such a big risk factor for Alzheimer's disease. It makes A beta accumulate inside of our central nervous system. So since we can't clear it, the only thing that we do is make even more A beta. It never gets cleared, and what it does is form these big sticky plaques. Now, even if you don't have the ApoE4 allele or diabetes, you still run the risk of developing Alzheimer's disease. Notice the dementia rate for non-carriers wasn't 0, it was still 4%. So what's going on there? Well, one idea is that folks who don't really use their brain very much are going to run into this problem that we're seeing here. So whenever you're just kind of sitting there keeping up with the Kardashians or doing what, some mindless junk, just kind of zoning out on the TV, watching things, this doesn't count. You're hopefully thinking and taking notes. But if you're watching some other junk on YouTube, that isn't my channel, you are damaging your brain. Okay, so when you're just vegging out, the default mode network is active. And this is just a network, a bunch of neurons, that are active whenever we're just not doing anything. So think of this like the engine is idling, and we see activity in these parts of the cortex. Hey, this is also the areas where we tend to see A beta plaques forming. The plaque deposition mirrors that of the default mode network. Oh, wow. And where we lay down plaques, that's also where we see the atrophy. So notice the places that degenerate first are the ones that get the plaques, which are the ones that are in the default mode network. So if you live your life without really challenging yourself cognitively, all you're doing is letting the same neurons be active. Those that are involved with daydreaming and not really thinking and solving problems. So those are the ones that keep firing action potentials. And every time you fire an action potential, you're spitting out A beta. Remember, it's activity dependent, right? So all of those action potentials, while you're watching the, reality TV do its thing, every one of those is spitting out a little bit of A beta and a little bit more A beta. So if the same parts of the brain are active, those are the parts of the brain that are just continually making A beta. But if you spread your activity out, watch a little bit of bullshit, read something else, do a crossword, go lift or something like that. Do different things, different parts of your brain are active, and you're spreading out that A beta load. That's the idea anyway. Who the heck knows? Maybe reality TV is good for us, but I doubt it. Okay, so these plaques and tangles that we make and that are characteristic of Alzheimer's disease, well, you might think that they're the cause because, hey, if you don't have them, you don't have Alzheimer's disease. Sure, but if you do have them, you might not have Alzheimer's disease. So we don't actually have Alzheimer's disease and plaques coming on at the same time. In fact, you can see a whole heck of a lot of plaques before we have any cognitive dysfunction. We know this now because we can do some, amyloid imaging while people are still alive. We have this thing called Pittsburgh compound B that'll allow us to look at amyloid while people are still alive. We long knew that you could find plaques in people without dementia. We're now seeing that plaques come on long before dementia. Plaques and tangles. So you have to lose a bunch of neurons until we finally enter the boom, demented stage. We have what's called cognitive reserve, meaning that there's a lot of neurons that accomplish the same task. So you got to lose all of them before that task is then lost. Okay, let's have a look at some Pittsburgh compound B imaging. So here we've got PIB negative, also non-demented. The PIB signal is all the red, orangey stuff. So there's a little bit, not much. We wouldn't call that PIB positive. Hey, this head is PIB positive. There's a whole lot of plaques in that head, but guess what? They're not demented. You can have plaques and not have dementia. Down here, we are demented and we have plaques, so the bottom row is showing us Alzheimer's disease, which you can see doesn't look that much different from this middle row. So plaques come on before the disease. So if they're causing it, that's kind of a problem. What we think is probably causing Alzheimer's disease is not so much the plaques, but the A beta oligomers that come off of them. So these plaques are big garbage dumps of insoluble proteins. And insoluble proteins probably don't harm you that much. It's the soluble ones that'll get you. So what we think is probably causing Alzheimer's disease would be soluble forms of A beta and tau. Okay, the blue is showing us a plaque. And this is either in a living mouse. We're actually imaging its brain through a hole in the skull. And this is post-mortem. So blue is the plaque. Red is showing us oligomers. There's an antibody that binds to oligomeric A beta. Okay, you can see them separate. It's much more informative when you look at them together. Ooh, we got a plaque and there's a halo of oligomers surrounding it. So what these oligomers do is then destroy the synapses nearby. Here's a plaque, but notice we're damaging synapses here and maybe a bit here, but not so much over here. So as you get closer, here we have a few different branches of dendrite. As you get closer to the plaque, notice you don't have to touch it. Just being near it is enough to lose your synapses. Okay, so we lose our synapses. What then happens is we impair learning. All right, so here I've kind of summarized a bunch of data. What they did was inject oligomers, A beta oligomers, into the little mouse brain here and then see, hey, how well do you learn? Okay, so here we didn't give them anything. We just injected some salt water. They learn in a normal range. When we give them the oligomers, they have impaired learning. If we give them an antibody against A beta, we don't impair their learning. And if we wait for more than a day, let ApoE4 do its thing, clear out the oligomers, hey, they can learn just fine 10 days later. But the next day, the oligomers are still around doing their thing, and that thing is preventing LTP, long-term potentiation. So when neurons fire together, they wire together. That's what's going on here. We're making them fire together, and ooh, their synapses should be stronger. But if you have A beta oligomers around, this doesn't happen. So the oligomers destroy synapses and interfere with long-term potentiation, which explains why they impair learning. The other thing they do is activate enzymes that then cause hyperphosphorylation of tau. That's what we're looking at here. Tau phosphorylation. Here's some normal neurons, nothing going on here. These were given A beta oligomers, and notice they're all really bright. That means they have a lot of phosphorylated tau. That phosphorylated tau then aggregates to form tau oligomers. Okay, what's the problem with these tau oligomers? Well, they slow down axonal transport. So here we're looking at axonal transport, anterograde, retrograde. And here we're looking over time. Now up here, we just gave them some normal tau, nothing wrong with it. You can see over time, the rate of axonal transport doesn't really change. These are basically flat lines, whether it's anterograde or retrograde. Down here, we put on this Alzheimer's-like tau. This has been modified so it's phosphorylated a bunch. Ooh, look at this. This is not a flat line anymore. After exposure to this Alzheimer's tau, these tau oligomers, we see a dramatic slowing of axonal transport. That means we're going to have a hard time putting synapses and mitochondria into the synapse. Synapses won't work. This is what we call synaptic starvation. Now, we think that tau oligomers are actually able to spread between neurons, kind of like prions, and this may account for the progressive nature of Alzheimer's disease to some degree. Kind of a newer idea, but what is clear is that tau screws up axonal transport. That is for sure a thing that it does. What A beta does is bind to NMDA receptors and stimulate them. Hopefully you recall that NMDA receptors are a type of glutamate receptor, and these are the ones that stay open a long time. First, let's take a look at the pretty pictures. Red is showing us A beta oligomers, and green is showing us NMDA receptors in panel A. In panel C down here, green is showing us GABA receptors. Notice, red lines up with green on the top, not on the bottom. So we think that the red oligomers are sticking to the green NMDA receptors up here, but they don't seem to be sticking to the GABA receptors. Okay, so what we're doing then when we stick to the NMDA receptor is helping turn it on. So if we put on some glycine and of course glutamate, we get a nice boom inward current. We turn on NMDA receptors. Oh, nice. If we just put on glycine, that turns it on a little bit, but we didn't have glutamate around. So we shouldn't expect much of a current. However, if you have that same amount of glycine, but let's squirt on a little bit of A beta, it's almost like glutamate is there. Whoa. So the A beta is stimulating NMDA receptors. Remember, these stay open a long time, and they also bring in a bunch of calcium, so we get classic calcium toxicity. But A beta doesn't need NMDA receptors. There's also evidence that it'll just stick into the membrane and make its own pore. That's what's going on here. They have a pipette. That's this dark thing right here stuck onto this neuron. And in the pipette, they got a bunch of A beta. Now remember, A beta used to live in the membrane. It's like half hydrophobic, so it can stick into membranes. So what they did, here's the cartoon up top, they put a pipette on and they waited. In this case, no A beta, in this case, A beta. And when they deliver a little depolarizing potential, they don't get much of a current. Look, nothing going on here. But with A beta in the pipette, not much. Ooh, look at that. And 20 minutes later, we get this really noticeable positive current when we deliver that potential. Here we can actually see the pore opening. What they did was put some fluorescent compound here. After 15 minutes, nothing. But after 21 minutes, that fluorescent compound started to make its way into the cell body of that neuron. In other words, we made a hole. And this hole is going to let all kinds of things move across the membrane, like ions like calcium, for example. So even without NMDA receptors, A beta oligomers could cause calcium toxicity. Tau is, of course, going to create a problem with axonal transport. Now, normally, tau is there to bind to microtubules and stabilize it. So here we're looking at the polymerization of microtubules. As we go from bottom to top, we're making microtubules from their building blocks. Give it normal tau, and it hugs the microtubules and gives them the pep talk they need to stick together. That phosphorylated tau, though, doesn't stick to microtubules as well. And notice, these microtubules aren't self-assembling as rapidly. Okay, so in Alzheimer's disease, we see a whole lot of tau hyperphosphorylation. What this can do is decrease microtubule stability. That's what we're seeing down here. We're seeing, let's say, unstable microtubules. Well, remember, microtubules are needed for axonal transport. That's going to be a problem if your microtubules aren't stuck together. It also seems to activate enzymes that make stuff fall off of kinesin. So it doesn't have to screw up the microtubules. There are other ways, but what I want you to remember is that hyperphosphorylated tau, right, which forms those neurofibrillary tangles, slows down anterograde transport. If you got that, that's good enough. So let's wrap up Alzheimer's disease here. I think it all has to do with an increase in A beta levels, because remember, look at those familial AD mutations. ApoE4 is a huge risk factor. So when you have too much A beta, what does it do? It polymerizes. It's going to form oligomers. It's going to form plaques. Those plaques will be a big ball of junk that might cause some reactive gliosis. That's never a good thing. The oligomers can then cause tau hyperphosphorylation to screw up axonal transport. Oh no, this synapse isn't going to work anymore. The oligomers can also act at postsynaptic sites, stimulating NMDA receptors and potentially causing excitotoxicity. And of course, that excitotoxicity is a whole heck of a lot worse because, we have reactive gliosis. We're not cleaning up the glutamate. So not only do we have more glutamate around, we have a bunch of A beta around, so NMDA receptors get hyperactive. And that's pretty much the problem in Alzheimer's disease, we think. A lot of glutamate toxicity and some synaptic starvation. So if we screw up axonal transport, no proteins over here at the presynaptic site, so it's not working. And some of those proteins, by the way, neurotrophin receptors. So that's going to be another problem. All right, moving on to ALS. We're still going to have problems in the cortex, but here we're going to have problems outside of it as well. We'll hit the lower motor neurons as well in the brainstem and spinal cord. We'll see some protein aggregates. We'll see some problems with axonal transport. So they got some common issues. Clinically, they look totally different, and Hannah will tell you all about that. All right, ALS, certainly not as common as Alzheimer's disease. This is also a disease of old age. We're going to see this occurring later in life. If this happens in childhood, we'd call it spinal muscular atrophy, and it'll look kind of similar. Here, rather than women having it rough, now men are going to have the problem here, and in particular white men, so we tend to see this in white males. The two notable examples are both white guys. So we got Lou Gehrig, baseball player, and oh my goodness, I had his name in my head. He's a physicist. This is embarrassing. Stephen Hawking. There we go, finally. I'm not going to edit that out. I want you to know how stupid I am. Anyway, they're both a couple of white guys. Now, as we increase age, notice what happens to the rate of ALS. It increases. And the men bars are higher than the women bars. Smoking seems to be a risk factor. So we got our never smokers here. We'll call their risk 1. If you smoked really late in life, cool. That doesn't increase your risk. And the earlier you started, to some degree, the greater the risk. I don't know what's going on there. I do know that most cases are sporadic, meaning only 10% have a family history. And another risk factor that makes a whole heck of a lot of sense is exposure to pesticides. These pesticides inhibit mitochondrial function, so that kind of makes some good sense. All right, the hallmarks of ALS are different and also to some degree similar to Alzheimer's disease. So we don't see like massive wasting of the cortex, but we do see massive wasting of the muscles. That's that amyotrophy. So we're not feeding the muscles, and that's because motor neurons are dead. So here's a normal cross-section of a muscle, and here's cross-section of a muscle that has ALS. Notice these degenerating, wasting muscle fibers. If your motor neuron is gone, you don't get activated. Use it or lose it. It's a rough life. So the muscle fibers that aren't getting used degenerate. We can see loss of motor neurons here. So we got two cross sections. Here's my ventral root, the motor neurons, and the dorsal root, sensory neurons. These are wild type mice, and this is an ALS mouse model. We see the same thing in humans, but this is a much nicer picture. Now the dorsal root looks fine. Our sensory neurons are still there. What's really affected is that ventral root where the motor neurons leave the spinal cord. Notice, we're not seeing all these nice axons. There's an axon, there's an axon, there's an axon, there's an axon. I can see one there, and that one looks strange. It's not myelinated. There's one there. So, yeah, we can see some axons, but clearly we've lost a ton of motor neurons here. Now, within the motor neurons, we still see protein aggregates. So we've got protein aggregation here, just like in Alzheimer's disease. It's a different protein. In this case, it's a bunch of neurofilaments that'll accumulate in the cell body and in the neurites that we can't see. So we'll see some in the axon and dendrites, but not in this picture. Okay, so protein aggregation. We also see reactive gliosis. We see this in Alzheimer's disease too. Hell, we see this in like every neurodegenerative disorder under the sun. Okay, so non-transgenic mice, here's the anterior horn where lower motor neurons live. Here's early and later stages in this mouse model. And the stain here is GFAP. This is an intermediate filament that gets upregulated in reactive astrocytes. In other words, the darker it is, the more reactive astrocytes we have. So none in control, a little in the mid stage, and a whole lot in the end stage. This is just a zoom in showing you here's where a motor neuron used to live, and here's a bunch of reactive astrocyte extensions right here. Now, the reactive gliosis that we see could both cause the motor neuron loss and also be a consequence of the motor neuron loss. Keep in mind, these are probably going to work together. So as we lose motor neurons, we see reactive gliosis. That causes more loss of motor neurons. That leads to more reactive gliosis. And we've got ourselves a positive feedback loop. These things almost never end well. In this case, we're getting ALS. There are other positive feedback loops like childbirth. That creates its own set of problems. The other hallmark that we see here is demyelination. This makes sense. If your motor neurons are dead, they don't have anything to myelinate. So we see demyelination in the corticospinal tracts. This is that lateral sclerosis aspect. So we see muscle wasting, and we see damage in the lateral corticospinal tracts. We also see it in the anterior corticospinal tracts, but, amyotrophic, lateral, and anterior sclerosis, I guess, doesn't sound as good. But that's what we're seeing here. So the blue stain is showing us myelin. Here's an age-matched control. You can see the gray matter in the middle here, not so much myelinated. See the myelin on the outside. And over here, this might look like an increase. Don't worry about that. You can just add the stain for longer. What I want you to notice is the fading right here and here. These are the lateral corticospinal tracts. Here's the anterior corticospinal tracts. Those are all the upper motor neurons. So when the upper motor neuron's lost, the myelin's lost too. The sensory tracts, like the posterior columns, unaffected. ALS is specific to motor neurons. All right, what's causing ALS besides exposure to pesticides? We've got several mutations, and I think we can lump these under two umbrellas. There's the SOD1 mutation, which I think is more related to protein aggregation. Now, SOD1 is an enzyme that helps scavenge free radicals. And you might think, okay, if we're not breaking down those free radicals, then they build up and we get oxidative stress. Sure, that's fine. It's just totally wrong. Some folks still think that. I don't want you to think that because you might have read the textbook. That's not true. If that were true, then the data that we're looking at here wouldn't exist. All right, so what's going on here is we're looking at the survival of large, that is the motor neurons, and small axons. So really we just care about the top here. Okay, here's what we should see in a year-old mouse, somewhere around 700 or so of these axons. Here's a SOD1 mutant that we see in ALS. So here's our ALS mouse model, and notice far fewer motor neurons. Okay, sensory neurons not really affected. Motor neurons, absolutely. All right. So if this is just like we've broken SOD1 and it doesn't work, let's reintroduce some SOD1. Well, that's not helping us. Notice we haven't fixed anything. Okay, maybe the mouse SOD1 can't rescue it because it's a human mutation. Boop, boop, boop. Let's go over here, add some human SOD1 to the mix. Still no effect. So once you have this mutation, regardless of what you're doing with SOD1, you can sprinkle back as much as you want. That doesn't fix it. This is not a loss of function mutation. This is a gain of function, right? So it is definitely not impaired free radical scavenging. This is not a loss of function. It's a gain of function. SOD1 is doing something it shouldn't. So as long as you have this mutant form around, it doesn't matter how much normal SOD1 you add. What that SOD1 seems to do is cause these protein aggregates that we saw. Now, what in the heck are they doing? Well, wait one slide for me. The other mutations, whether it's in TDP43 or the C9 open reading frame 72 or FUS or something like that, these all affect gene expression. TDP43 is a protein that seems to probably shuttle RNA from the nucleus to the cytoplasm. So if you don't move RNA out of the nucleus, how do you turn it into protein? That's obviously going to be a problem. C9 open reading frame 72 is really interesting because you see it in about half of the cases of ALS, and it's in an intron. That means it has nothing to do with the protein. What we think is going on here is that this mutation affects RNA processing. So you just screw up like all the RNA, and so we get this improper gene expression. Let's just make those our two categories. One, we got these neurofilament aggregates, and in the other category, we got some problem with gene expression. All right, what does that do? Well, if we have some problem with protein production, that's clearly going to screw us up because proteins do everything in life. What about those aggregates? What those protein aggregates do, those SOD1 induced aggregates, is, I believe, decrease axonal transport. So the same thing as in Alzheimer's disease, but it's a different protein. It's not tau, it's SOD1. What we're looking at here are these little chymographs where we're following fluorescently labeled mitochondria over time. So top is early, this is later. Some mitochondria stand still, that didn't move. Others move in the anterior direction. Notice this is kind of shifting to the right as we move from top to bottom. And others move in the retrograde direction from right to left as we go top to bottom. Okay, you can look at these are wonderful, but we can also just look down here at the quantification. So how many mitochondria were moving? If I give you some more SOD1, it doesn't change. If I give you the mutant SOD1, fewer of them are moving. And in particular, we see fewer of them moving in the anterograde direction. Again, synaptic starvation. And if we're also not moving our neurotrophin receptors down the axon, we're going to have impaired neurotrophic support. That's clearly not a good thing. If we have a whole bunch of protein aggregates, well, that can cause an unfolded protein response, and we see signs of that in ALS. And hey, if you're not making the right proteins, how are your mitochondria going to function properly? This is clearly going to be an issue as well. Now, ALS can be caused by problems in astrocytes alone. So it might not actually be anything with the neurons. It's a problem in the astrocytes. So astrocytes are going to play a big role here. Let's give them their due attention. So we saw an increase in GFAP expression earlier. As we entered the later stage, we saw more GFAP. That's reactive astrocytes. Now what we're going to look at is the expression of glutamate transporters, EAT2. So here's a non-transgenic mouse. Notice EAT is all in the gray matter. So we got glutamate transporters all in here where we're forming synapses. And let's have a look over here. Hey, notice that anterior horn is noticeably less brown. That is, it has lower levels of EAT2. So as we're becoming reactive astrocytes to try to, quarantine the area of damage and deal with the dying neurons, we make the problem worse. Because while we're pumping up our cytoskeleton, we're decreasing expression of glutamate transporters, leading to glutamate toxicity. And in fact, if you were to look at glutamate levels in folks with ALS, you see they have a whole lot more glutamate in their CSF. This is kind of similar to how like meningitis can still get glutamate toxicity like we talked about. Obviously, the end result of that is excitotoxicity. So, end of the lecture. Let's get another one of these nice flow charts here. I use the word nice very liberally. Okay, so maybe it's SOD1 causing that neurofilament aggregation. What might happen? Well, if you got protein aggregates, you might get an unfolded protein response. What could that do? Well, that can kill you by apoptosis, or it can trigger reactive gliosis that'll then kill you by excitotoxicity. Because remember, the unfolded protein response in an astrocyte triggers reactive gliosis. The other thing that those neurofilaments can do is decrease axonal transport. And then that leads to decreased neurotrophic support, triggering apoptosis. Now, those alterations in gene expression, what can that do? Well, a lot of things. Maybe you're not making your neurotrophins as well, like those FUS mutations. Clearly, that's going to cause apoptosis. Hey, maybe you're not making the correct mitochondrial proteins and your mitochondria don't work correctly, and apoptosis, of course. And alterations in gene expression can also cause reactive gliosis and an unfolded protein response, and you can follow those lines to their excitotoxicity and apoptosis ends. And then, of course, exposure to pesticides, which impair the electron transport chain in the mitochondria, directly induce mitochondrial dysfunction, leading to boop, 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 apoptosis. Alrighty, if any of that stuff seems a little tricky, put your questions in the questions box so I know what to talk about. I'll see you later.